Welcome everyone to the Better Breathers Club of BC. As we get started today, this is a joint effort on behalf of the BC Lung Foundation and Poplar Pulmonary Wellness. Today we're going to be talking about the truths and myths of inhaled steroids as well as other steroids. I am Tina Sue. I'll be one of your hosts. Jenna Jangali is your other host, as well as Men is here from the BC Lung Foundation. So if you have any questions at any time, please do ask. And as we start here, we'd like to do a quick land acknowledgement. We are coming at you from the lands of the Coast Salish peoples. These are the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And if you would like to share the lands on which you live, work, and play, please feel free to do so in the chat. And we like to create a safe space for discussion. So feel free to share your thoughts, values, and opinions, and to ask questions without fear of judgment. So we let everyone talk and say their piece. We also do get off topic a little bit. So if we get too far off topic, we might nudge you back into onto the topic at hand. And any information here is not a substitute for professional medical advice from your personal healthcare provider. This is provided as an educational purpose. But first, let's start with some trivia. I'm going to stop the screen share for a second. All right, so we're going to do a thumbs up or thumbs down version of the trivia. So if your thumbs up is a yes and thumbs down is a no. Oh my. Sorry. I can't see my notes. Hold on. Okay. All right. So first question is, we have 5 quick questions. First one is, do you take an inhaled steroid regularly? Well, a lot of yeses, bit of a mix. Okay. Have you ever taken steroid pills? Okay, bit of a mix. And have you noticed the benefits from taking any of these steroid medications? Mixed. Yep, no. Okay, that's what we're going for. Perfect. Have you noticed any side effects that you don't like? Okay. Oh, sweet. Oh, interesting. Oh, that's different than I was expecting. Do you have any questions about steroid medication?
Oh,
Okay. We're gonna start off with the questions. So if you'd like to type your question in the chat, please go for it. Or if you'd like to ask your question aloud, we'll record them for now and then we'll make sure that we get to them during the talk. Jen, if you're okay to write those down. Okay.
I'm on chat box patrol, so I'll be writing down all your questions, those of you using the chat box. And if anyone wants to get started with a verbal question, feel free to go ahead.
is a corticosteroid the same as a steroid?
Perfect question. Okay, I'm just gonna put that in my vault.
Now, this Alvasco steroid, I've been on it for years, never had a problem at my pharmacy. But lately they've been pulling me aside because I'm taking this and they want me to be aware of it. Like I've never had that before, but the last probably 3 times I was out there, they took me aside. So I have no idea what's so special about that. Or I don't know why.
What did they pull you aside for?
Just to make me know that it's a steroid, and so that's
okay. Okay.
Yeah.
They wanted you to
Maybe
really know.
Alvesco as a steroid? Why is that important? We'll
Yeah.
frame it as a question,
Okay.
like Jeopardy.
Yeah. Okay, we got one about prednisone.
Shirley, Jeannie, great questions in the chat. I've got those. So Shirley, just wanting to learn about treatment strategies. And yeah, sounds good. And then Jeannie, is prednisone considered a steroid?
Okay. Perfect. All right, I'm gonna do my best effort to bring my slideshow back up again, and we'll start talking about the steroids. Okay. All right, well, what are steroids? What the heck are they? So a steroid is a short form of the full word corticosteroid. It's a corticosteroid is what we're talking about. We're going to come back to that. And there are 3 types of corticosteroids. So there are glucocorticoids, mineralocorticoids, and androgenic sex hormones. And when we talk about steroids, we're talking about glucocorticoids. So a glucocorticoid is a type of a corticosteroid. Mouthful. And steroids come from the adrenal cortex. And that is a part of the body on top of your kidneys. And the word renal is like a medical term for things to do with kidneys. So adrenal meaning on top of your kidneys. And I'll show you a picture here. So this is the adrenal gland where corticosteroids come from. So the brown part, can you see my mouse here? So this brown part is one kidney. This is one kidney. And then the adrenal gland sits on top of the kidney. And this is a cross section of it. And the cortex is the outside, there's an outside capsule, but then basically the outside area of the adrenal gland is the adrenal cortex. And the adrenal cortex is where corticosteroids come from. So on top of our kidneys. And the kidneys are located in the upper abdominal area towards your back. So kind of in the mid-back area. And so when we talk about steroids, we like to put them in a couple. So we're talking about glucocorticoids. We're talking about corticosteroids here. Local versus systemic. And there is a big difference here because we talk about inhaled steroids a lot when it comes to managing chronic lung conditions. And so an inhaled steroid would be a type of local steroid, meaning you put it in the place where you want it to act. So like you can have steroid creams, eye drops, nose sprays. And the advantage of putting medication in a local area where you want it is that that's the first place the body is going to be able to absorb it. And then those cells that are close to that area are able to absorb most of it, and you get a bigger impact in the area that you want. And there'll be less of it available to go through your bloodstream and go over your whole body. So local steroids have that advantage, but systemic steroids, you usually take a pill and it goes throughout your whole body. And sometimes we want that effect. So we might want things to take effect in our whole body, like with autoimmune conditions, or if you have a lung transplant, you might want these steroids to take effect in a bigger area. And so the way you give a steroid affects the dose needed and the amount of side effects that you're going to feel. So these are some, I'll say it's like pros and cons, pros and cons to local steroid versus systemic steroid. And so because when they're local, most of it goes to the one area, you get less side effects. But sometimes it's those side effects you want. And so if it's in the whole body, then that's a good thing. So yeah, just kind of taking note about local versus systemic. And usually a local steroid is taken longer term when it comes to managing a chronic lung condition, and a systemic steroid might be taken shorter term to manage exacerbations. But if you're taking them for other reasons like autoimmune diseases or lung transplant, you'll be taking a systemic steroid for longer periods. And that's usually where we see a higher risk of getting those side effects. And steroids do have a long list of side effects. And the side effects, most of these side effects are dose dependent. So if you're taking a low dose steroid, you're not as likely to get the side effects, and time dependent. So if you're taking them for short term, you're not going to be as likely to get the side effects compared to taking, for example, a high dose for a longer period of time. And that is a notable difference between the side effects. Also, if you're taking a local steroid, you're probably not going to get as many side effects or chances of side effects compared to taking a systemic steroid. Yeah, so some of these side effects can be quite pronounced, things you don't want to get. Other ones are more annoying than anything. And so when it comes to taking steroids, you really have to balance the pros and the cons. Oh, I forgot to answer one question. When we're talking about systemic steroids, prednisone is a great example of a systemic steroid. Anything that's in a pill would be considered a systemic steroid. And so it's all about balancing the pros and cons. And so the two main things that a steroid can do is reduce inflammation. That is a big, big benefit of a steroid. And they can also reduce the effectiveness of the immune system. So you get decreased immunity. And sometimes that's what you want. If you're managing an autoimmune condition or if you've had any transplant, you're going to want to decrease your immunity so that your body doesn't fight off itself. But if you don't have one of those two, then you probably don't want the decreased immunity because it can open you up to getting infections just in general because your immune system doesn't work as well. So I would say the most important thing is to take the steroid that you need to manage your lung condition, and chronic inflammation is one of those goals. So when it comes to the lungs, they do get inflamed from all kinds of things. Smoke, anything in the air, allergic triggers, it could be change in temperature, humidity, exercise even. So there's a lot of things that can cause our lungs to become irritated and get inflamed. And when lungs are irritated and inflamed for a while, they can start scarring and they can start changing. And you would notice that as a worsening in your breathing. So reducing chronic inflammation is very important for all of us if we have reactive lungs. And then the other thing that a steroid can do for an inhaled steroid is reducing your risk of having an exacerbation. And so if your lungs are in a state of inflammation, you might not notice. Really, you might not notice. You're breathing, you might feel like now this is normal for me. But taking an inhaled steroid can reduce the inflammation either with triggers like intermittent inflammation or a constant level of inflammation that might be underlying that you have grown used to. So by doing that, it reduces your chances of exacerbation and it can help resolve the exacerbation faster. So it'll make it less severe. And so this is a really big benefit because angry lungs are unhappy lungs, and having an exacerbation is a risk. So we know that people who have a lung flare-up or a lung exacerbation are more likely to have a cardiovascular event within a year of an exacerbation. So that could be like a blood clot, like a stroke. It could be a heart attack, or a change in your heart status. So that's one thing. We also see worse outcomes. So people get other chronic conditions that develop, and they have a higher chance of dying within a shorter period of time. So having an exacerbation is not good, and it's really important to prevent them. And
One other thing I'll just add in along with that is once you have your first exacerbation, you're more at risk of having more. So that's where the corticosteroids come in to kind of prevent that. And the higher risk of cardiac effects like heart attack, that was mostly seen in those with COPD.
yeah, the data, thank you. Yeah, a lot of the data comes from COPD patients because that's a very large population. And with our aging population, there's a lot of research going on with those groups right now. So we're seeing a lot of inflammation. Well, we are too, but we're seeing a lot of data come out from that group. And often what we find is that it is applicable to other groups, but maybe we don't know that just yet.
Can I add something too?
Yes, please, man.
I usually giving physicians or your healthcare professionals will give you the steroids only when it is really, really necessary, as what Tina was saying. When there is an exacerbation, that is because that's the fastest way to control inflammation. However, if it is taken within the therapeutic dose or amount that your physician gives you, I would suspect that I can't really say there is not a lot of side effects. However, if at some point you're also immunocompromised or something like that, then that could be a different story. So your doctor will really, really determine the benefits of giving you the steroid, right, over the side effects, against the side effects. So those are the only things that you need to remember. You're given it is because you have a very concerning infection or inflammation going on, and your inhaled corticosteroid may not be enough to control it. And so you're given the steroids. It is safe provided you take it within the prescribed dose.
Yeah, that's a good point. Thanks, man. Yeah, and the side effects are, sort of dose and time dependent. So if you're only taking it for short term, that might be a lower risk of having the side effects. And I'll mention too, there are, if you do get a systemic steroid and you have to lower the dose or you're done with it after a longer period, they have to taper it back because there's different side effects that can happen from stopping a corticosteroid too quickly, because the body stops making its own corticosteroids. So you need to let it kind of pick up and make its own in the right balance as you cut back on those medications.
Yeah, and following up on that is that you don't stop the steroid even if you feel better, as long as you have not finished or completed the treatment, because sometimes the steroid acts so fast, not so fast really, but acts on earlier, and you find yourself better. You don't have to stop your corticosteroid until the last dose that your physician tells you to take.
Yeah, good point. Thank you. And one thing, this is actually from Jenna. Jenna says, tame the flame. So the flame, it's like the inflammation in your lungs. I'm listening, Jenna. Did you want to talk about this? This is literally the tame the flame slide. Or do you want me to go?
Sure. Yeah, sure. No, yeah, I can. So often when I'm coaching people through treatment with corticosteroids, I often explain it, if we take our airways as an example, so they're inflamed. So think of that as like a fire. So your airways are on fire. And when we want to tame that fire, we're not just, and when the fire is really bad, as an example, so for, let's say, just as an example, let's say you've got asthma airways and you're in a flare up or an exacerbation of your asthma. So that fire is really bad. That is a lot of inflammation in those airways. So when we go to beat that fire, we're not just going to sprinkle some water on this huge fire and hope that it goes out. We're going to give it the big guns. And that's often this tablet, systemic course of prednisone often. Because we want to douse it completely. So often, exactly like Men said, a therapeutic dose that's right for you, it might be on the higher end, but the goal is to put out that fire quickly. Usually courses of prednisone, we call it a short course. So they're somewhere between 5 and 7 days usually. For an adult, maybe somewhere between 30 to 50 milligrams a day. And we douse that fire as quickly as we can. So when you're doing those pros and cons and maybe worried on the dose of a systemic corticosteroid, this picture hopefully stays in your mind, because that's what we're trying to do.
Nice, thanks. Yeah, and this flame, so if you want to think about it, like maybe normally your lungs have like some smoldering going on. It might not be like full on flames, but the smoldering can lead to lung damage as well. And you might not really notice it till later, but at that point, the damage is done too. So this is why we really want to get on top of our chronic lung conditions and manage it very well early on before the lungs have had much damage at all. So if we can just manage it early, then the lungs can stay better for way longer, as opposed to, having these, we literally call them flare up, right? Like thinking of the flame. And in these times where it flares up and it'll get better and it'll flare up and it'll get better. But what happens is over time, these, one-time kind of flare-ups end up doing more damage. So if we can focus on prevention, which is one thing that we really try to encourage people to do, which may involve taking an inhaled steroid regularly. And we know there's a lot of myths out there about steroids, like you're gonna get a hairy lip. What are you going to the gym? But those are those androgenic sex hormones, and that's not the steroids that we're talking about. These are two different things. So we're talking about steroids that reduce inflammation. So think of this flame whenever your lungs are feeling a little tight.
And Tina, I'm not sure if you have this in a later slide, but did you want to talk more about what this damage is that people can be susceptible to when we let the inflammation smolder or stay flared up?
Sure, and I'm gonna stop my screen share too, because that's kind of the last slide for a minute while we talk and share experiences. Yeah, so fibrosing and scarring, is this what you're talking about? Yeah, so the lungs, let's just talk about inflammation for a sec. So what's inflammation? Because really, this is what the steroids are trying to prevent or control, at least control inflammation. And inflammation is a protective mechanism from the body. So the original purpose of the body getting inflamed is good. So if you think about, I don't know, you got a splinter, let's say, it's going to get like red, there's going to be a bump, there's going to be swelling. And so it's because the body is calling the blood over. Hey, blood, bring me some help. I want to get this thing. Something's wrong, right? And so the blood goes there. And that's partly how we get inflammation, is just there's more blood there. Tissues get a little thicker because they're full of blood. but the blood brings help with it. We call them inflammatory mediators. Oh yeah, lots of cells and chemical messengers that come along to help get rid of bad things in the body. And so in a lot of situations, this helps us. It can help bring a splinter out. It can cause bleeding, which can flush out a wound. So inflammation is a good thing in terms of self-defense. But chronic inflammation is a different thing. It's a different beast. And chronic inflammation is not good. Chronic inflammation in some areas of the body is going to cause pain, like if it's in your joints. Any of those conditions with itis at the end. Itis means inflammation. So if we have a lungitis, the lungs are inflamed, and we don't call it lungitis, but the lungs can be inflamed and you can't see it. You can't see it. And if it's kind of widespread throughout the lungs, you might not really notice it because, especially if it onsets gradually. And so, and often too, we don't notice it because we get sick. We know there's inflammation. I'm coughing up mucus. All these things are happening, but then you get better. And it's very difficult to compare where you are after a flare-up compared to where you were before. You know you got better, but did you get just right back to where you left off? And often we don't see that. So yeah, chronic inflammation is bad, and these inflammatory mediators cause other cells to be there, getting in the way. And lung tissue is so thin and delicate. Oh my gosh. In order for a lung to work, you have air that you breathe it in, and then you've got your blood. And between the air and the blood in the alveoli is a one cell. It's one cell thick, your alveoli. So you can imagine it's like a sponge of all these billions of alveoli, but each one is very delicate. And oxygen has to go from the air into your blood. And it literally has to diffuse across a cell. So you can imagine if that cell gets inflamed, it's a lot harder for the oxygen to go into your blood. And the same thing with carbon dioxide going from your blood back into that air for you to exhale. And so because this membrane, we call it the alveolar capillary membrane, it needs to be thin for us to breathe. And inflammation makes it thick. And eventually, this is the scarring. So it's thick and it's permanent. So the lungs do not repair very well. Okay, they can have temporary inflammation that can go away. We can have secretions that can go away. But once there's scarring, that's it. So we cannot improve the lungs. Treatment is usually focused on improving the rest of the body to work better and more efficiently with the lungs that you have. So your lungs are so precious. Our liver can regenerate, but our lungs can't. So it's really, really important to do this prevention piece. And we know that, you know what, steroids doesn't sound like a good thing, but they're a wonderful game-changing medication that allow people to live wonderful lives, keep their lungs in check for long periods of time. So I can't emphasize enough how important it is to keep the inflammation down. Yeah. Was that a good rant? So maybe I'd
So
like,
maybe,
go ahead.
yeah, we'll check in here and see if there's any other burning questions that come up. And then it looks like we've hit the initial questions. It looks like we've hit most of them. Maybe maybe if there's no other questions, we'll pop back to Bobby's question about the Alvesco.
Yeah, what are your thoughts as you're hearing all this stuff too? Because it's big stuff when it comes to chronic disease management.
Is Trelegy a steroid?
Yeah,
Yes.
Trelegy. So when it comes to medication, very often the inhalers that have a steroid, a lot of them can be combined with other medications. So often you might be started on a non-steroid inhaler, And then maybe if things got worse, or depending on your lung condition, they may start you with a combo inhaler. And so Trelegy has 3 different medications in it, and one of them is a steroid. Yep. Yeah, good questions.
So Jeannie was just sharing her experience in the chat. So she says, I had IV prednisone in hospital last year at home, and she began, when she got at home, she began with 50 milligrams of a pill form of steroid daily, and then she had to titrate down over 5 weeks. So thanks for sharing that, Jeannie. During that time, so that's a bit of a higher dose, and of course, anything IV in hospital as a medication option is just a quicker way to get that steroid to the body. And then when you go home, we need to change how we deliver that because you're often not getting IVs at home. So it got changed to a pill. And then, like we've been saying, it needs to get titrated down. And the way that I usually explain this is if you remember that picture Tina showed of the adrenal gland. So your adrenal gland is already sort of meant to produce these corticosteroids kind of naturally. But when we give it in a pill or in an IV, we say that that's exogenous to the body. So sort of like outside of the body coming in, that adrenal gland goes, well, I don't need to work as well. See you later. I'm going on vacation. It starts to slow down a little bit. So the reason why that taper is so important, and Men was reminding us that even if you feel better, continue the instructions, especially with the prednisone, because we need to wake up your adrenal gland slowly. We need to say, hi, like the exogenous corticosteroids are going away. You need to start producing what you were before. And so that taper helps to be able to do that so that you don't end up with big sort of crashing side effects.
Yeah, and then the like the body will notice that you've cut back, and then it will start to increase the endogenous, the stuff that it's creating. And so there's a little bit of a lag as you cut back. And it's within that lag time that you might start to notice some of the side effects. The side effects of coming off of something like prednisone are just sort of a general type of side effect. So it could be like in your gut, like a vomiting, diarrhea, unwellness thing. It can be a generalized stuff, headaches. So people can feel a little bit unwell as they go through if you taper too quickly. So follow the instructions about the taper, and it's designed to keep things regulated smoothly as you go.
Hi, Tina. Sorry, I just have to add a little bit on what you have said. Okay, so the Alvesco one
Oh,
is
sure,
used
yeah.
to treat. It's an inhaled corticosteroid, but it's not the usual one that you take in, the Flonase or what is it, Flovent or something. It's a different kind of inhaled corticosteroid called cyclosinide. The good thing with Albasco is that it has this HFA as a propellant, which is very, very soft on your throat. So a lot of people likes that, unlike some other inhalers where it's not HFA, and then they usually get some kind of, it's not as soft as it arrives in your throat. So some people feel nauseous about the other inhalers, but this one is very soft. But it is not a rescue medication. It should not be used as a rescue medication. It is an inhaled corticosteroid. And with regards to inhaled corticosteroid, it takes about 2 to 3 weeks before it really, really takes effects. And that is why we are warning people. You don't get better right away if you take in your inhaled corticosteroid. It takes some time and it builds up. Once it starts working, it builds up over months. So it takes a while, so you don't worry, or some people are so worried about it that it's not working. So if you are an asthmatic patient or asthma living with a patient living with asthma, what happens is that you always rely on your rescue medication, and you think that the rescue medication is the only one that is working for you rather than inhaled corticosteroid. So it takes a while before it takes effect. But once it starts taking effects, it continues as on for months until, and you have to take this regularly. And I said, you may start feeling better after a month of taking it or after 3 weeks once it takes effect, but do not stop your medications until your doctor tells you to do so because it takes a while or months, depending on the severity of inflammation that Tina was telling you, all those inflammatory cells that is happening in there. So the chances are it takes a while to treat the inflammation or to control the fire. And therefore, it takes you for a long time, or some people may even take it for 6 months or even longer, depending on the findings of your doctor. And that's the reason also, if you're taking an inhaled corticosteroid and your symptoms are still um, present or you're not able to control your system, your symptoms, then it's a must that you go back to your doctor and have you reassess or reevaluated whether they may have to increase the dose of your inhaled corticosteroid or may put you on to trilogy, which is a combination of three medications, your long-acting long-acting bronchodilator, an antimuscarinic, long-acting antimuscarinic agent, and your inhaled corticosteroid. So it's always a must that you have to go back to your doctor or to your respiratory therapist and ask them, I've been taking this inhaled corticosteroid and my symptoms are not improving.
Thanks, and that's great.
Sorry.
Yeah.
Just
And
wondering if
even
you could, just wondering if you could repeat the name of that inhaler that you said at the beginning, the one that you said is soft on the throat.
Oh, Alvesco.
Thank you.
The other reason why Alvesco is a common corticosteroid inhaler that is used, especially, let's say if you're already on a sort of maintenance inhaler and you need a little extra. Alvesco is the one that they use for the reasons that Men said, but also it's a pro-drug. So what that means is it doesn't actually get activated until it hits esterase enzymes in your lungs. And so what that means is you tend to get a lot less upper airway side effects. And some of the common inhaled corticosteroid side effects might be thrush, like a yeast infection in the mouth, hoarseness of the voice, irritation in the mouth, or the voice box. So that's often why you're encouraged after an inhaled steroid to rinse your mouth with water, gargle, get it as far back in your throat as much as possible, and then spit that out. Because what we're trying to do is collect any medication that didn't get down in your lungs, and we're trying to get it out of the mouth. So sometimes if you're on a maintenance that might already have a corticosteroid in it, but you need a little bit more, they often add Alvesco on because then at least you're not getting all of these upper airway side effects.
nice. And I'll add to like, oh, sorry. I was
Sorry.
gonna say,
No, it reminds me, Jenna, when you say rinse or gargle. I usually, because some of the patients says, I drink water just after. Right. Okay. So that's one of the things that most patients does. But I usually advise them to better just brush your teeth. So take it before brushing your teeth in the morning and brushing your teeth in the evening. So you take it all always at the same time, the same on the same every day, and that it removes a lot of this powder that is stuck in your dentures, in your teeth. So if you are wearing dentures, you better make sure that you clean and brush your dentures as well, so that that doesn't give you the oral thrush that Jenna was talking about, or better, yeah, better rinse. There's so many things that patients think about, and this is a good way of discussing it. If you have other concerns, bring it out right now, because this is the best time for us to address some of those. Who knows, you may be doing the right thing or may not be doing the right thing, but letting us know, we may be able to give you some rationale for it, or
So Colleen also had another question in the chat, and maybe actually I'll post it. I'll let the group kind of answer because I know we have some participants out there that know this. So Colleen's question is, can you define an exacerbation in your lungs when you've been diagnosed with COPD? So if there's anyone in our group that has maybe experienced an exacerbation or knows what one is, feel free to speak up, or you could write it in the chat box too. It's a great question.
Yeah, and so important to know too. How do you know when you have one? I love that question. What kind of symptoms might you notice?
I just wanted to make a comment about Alvesco before you move along to the other members that are participating today. I've been taking Alvesco for many, many, many years, and I did question my respirologist at the time, who explained, as Tina and Jenna and Min have, and I have not had a flare-up in over 6 years. So it really is good. It is a good steroid to take, and you have to take it properly, so it does work. So anyway, no flare-up in over 6 years. I'm happy with that.
Yeah,
Yeah,
cool.
go ahead, Stephen. No, we can't hear you, but you're not on mute. You might have to unplug the headphones. No. I don't know if there might not be a microphone on those headphones. Maybe can you unplug them from the computer? That might help.
Can you hear me now?
Yes.
So I had what would be what is it called again?
Exacerbation.
Exacerbation?
Thank you very much. But that's before I had any kind of diagnosis of COPD. I ended up in the hospital, and they didn't even tell me I had COPD, but they sent me home. I took Prestone. I think I took, they gave me one. I was there overnight kind of, and so I almost choked to death. I had to call 911, and I was this close to not. I had to wait 40 minutes. I was hanging out my window here, just sucking air in. And I had no idea that I had COPD. But anyway, so I got there, and even that, they gave me, I ended up twice. So that first time, they didn't say I had a COPD. The next time I had this exacerbation, I went, because I wasn't really on any medication, and so I was given Prestone when I was in the hospital, and I took 2 the next day, and that's the only time I've taken it. And this last winter, so I've been on medication now for a couple of years, and both of them were sprayed. They're whatever they are. No, like puffers. Sorry, both of them were puffers. One is for emergency, and every morning I took this. And then I had what I guess call an exacerbation or something in February of this year. And then I went to the lung clinic at St. Paul's, and they gave me allergy. Is it called allergy?
Oh, Trelegy?
Trelegy, yes, Trelegy. I mean, to me, it's a miracle drug. It's amazing. I did have a belt of pneumonia this summer. But it was pretty mild, and I was only kind of out of commission for a week. But aside from that, I hardly ever produce any phlegm. And it's very rare for me to have any kind of cough. I have allergies in the spring, so I got this in May, and I mean I just zoomed right through without any problems. So I don't know how long this will last, but I'm so grateful to have it. And so one of the things that I do when I do it now, I live alone, so I can do lots of things that you can't do if you or don't want to do in front of other people. But so every morning I take the Trelegy, and so I go to the kitchen. I go to the kitchen sink and I gargle 3 times, and just clean out my mouth. That's what I do. It's very easy to do. That works for me. So anyway, those are my experiences.
Well, thank you so much for sharing all of that, Stephen. And I'll just make a quick comment too. So your story, unfortunately, it's not uncommon that people, have a chronic lung condition and they don't get diagnosed until their first flare up, their first exacerbation. And that is often how people find out about it, which is really unfortunate because if it had been diagnosed earlier, you could have maybe avoided that first exacerbation. And once you've had an exacerbation, that's the risk for future exacerbations. Unfortunately, that's the main indicator. So I'm glad to hear you've got the right medication, you're on full force meds, taking them regularly, you see the benefit. This is a success story because too often people don't realize that they still have a disease that needs managing. So I'm really glad to hear you're on top of it. And coming back to Colleen's question there, you just named a bunch of things that actually would tell you if you do have an exacerbation. So you talked about mucus production, you talked about cough, and shortness of breath. And so these are 3 of them big symptoms that you would notice a change in if you were having an exacerbation. And Stephen, you also mentioned pneumonia, and this is a very common cause of exacerbations. If you have a pneumonia, that's an exacerbation.
Well, just so I've never had pneumonia, and
Okay.
I just noticed that I was producing a little bit of phlegm, but I noticed there was like spots of blood, and so that happened for 2 days, and then I took myself to St. Paul's Hospital, Emerge, and again they gave me it took them a long time to figure out if I did what I did have. And then I took antibiotics for 5 days, and then it was gone. But you kind of, so looking for that blood, if you happen to see a little bit of blood, that's a symbol that's important that you follow up.
Yeah, the signs and symptoms of an exacerbation are different, can be different for everyone, and you may start to notice a pattern, and you may start to notice really warning signs if you're having one. So I just put Jeannie and I actually in the chat box just further defined exacerbation, which is really just this marked period of increased inflammation that can cause bronchoconstriction. So the muscles around the airways can tighten. And with that inflammation, it causes a lot of obstruction in the airways. And the way that you might notice you're having one is what Stephen's been saying, and what Jeannie put in the chat box, which is that you're noticing a change in your symptoms from baseline. And again, Stephen didn't even realize that he gave us another tip, which is there's this 48-hour mark of persistent symptoms, so 2 days without a change. The symptoms can look like increased shortness of breath, more cough, more mucus, maybe even a change in color. Like Stephen was mentioning, his change was he noticed it was blood tinged, which can happen for some people, but maybe it's a change in your regular color. Like if it's yellow and that's normal for you, but now you notice it's a darker yellow, or it's a green or a brown or gray even, and it persists for 48 hours, that's a change and could be considered an exacerbation.
Bobby, I think you had a question.
Yeah, no, I just, now the triggers, like I've got asthma and some floral triggers it, definitely perfume, definitely smoke, and sometimes cold and that sort of thing. That triggers my asthma, which makes me cough. And I, have a great big huge cough to a point where I'm just about, out of breath. I just trying to find my breath. But that happens when I do these things. And like sometimes, and I stay away from it, but sometimes like you go somewhere and somebody's shopping, they got perfume on, like, whoa, or anything like that. And you just think, why would you, and so then I have to scoot out real quick, or if I smell smoke, I run out right away because I don't want to have this great big huge coughing fit. It's like a coughing fit. And laughing makes me do it too. So I can't laugh with I'm not telling you. I can't laugh with my family, with my sisters. We don't laugh anymore. We just sort of chuckle because I can't laugh, because then I'll just end up, getting coughing so much, I'll just run out of breath. And at that point, I can't take my blue puffer because I can't even get a breath in. Like I'm just trying to get a breath. So, but it doesn't persist for 48 hours.
Yeah,
Hi,
so
Bobby.
Yeah.
Oh, sorry.
it's okay.
Go ahead, man.
Hi. Okay, Bobby, those are very typical things that can trigger your asthma. So the best thing to do is really try to avoid those. Any viral or cold infection or any bacterial infection can trigger your asthma. Even those, what do you call this, perfume scents or anything can trigger your asthma. In this case, though, if you happen to be in the mall or something and you had this, when you encounter your trigger and then you start coughing a lot, then you have to take your rescue medication or your blue puffer.
Yeah.
So you have to have that with you all the time.
I have it all the time, but what I'm saying
That's
is I
good.
cough so badly that
Mhm.
I just can't even breathe. And I
Do you?
can't take my blue puffer. I have
Yeah,
to wait until my body goes through it and I can breathe.
right.
And
Do
then I
you
can take
have
my,
your spacer, your airy chamber? Do you use
yes, I have it on their train.
Okay.
Yeah. But anyway, just the way I cough.
Thanks for thanks for sharing, Bobby. And we should make a little differentiation here. So Bobby's mentioning asthma, whereas when we were talking about exacerbation, we were talking sort of a COPD, this 48-hour mark thing. And asthma, it's a little bit different.
Different.
So asthma exacerbations, the same things are happening. There's increased inflammation, but your time markers can be a little bit different.
Yeah.
And like Bobby's explaining, the symptoms can persist and happen very quickly. And the thing that first comes to mind for me, Bobby, is that maybe your underlying asthma isn't as controlled as maybe we could get it. And I know you've had some changes
well,
recently. Yeah.
I do take one medication for asthma, but like by pill, by mouth, but I don't.
Yeah. Yeah. Feel free to reach out to us after, Bobby, if you want to kind of go through your asthma plan.
Okay.
But we're already at time, everybody.
I know, I can't believe it already. I'll just do a quick screen share and we'll do one more thing before we say goodbye. First of all, thank you everybody for joining in. What an amazing discussion. I absolutely love this. I absolutely love the questions. And hopefully we help to provide you with some answers. But you can post your questions in the Poplar community at any time. Just post them in the big chat area, no problem. We can provide some answers for you there. BC Lung Foundation we have another Better Breathers Club coming up every month. So the next one is in November on Wednesday, the 13th of November at 2 p.m. Next week, Poplar has another free online Zoom event. This is a chat and chew, which is similar to this. We have a guest speaker coming in and we're talking about a palliative care approach. That's next Tuesday at 2 p.m. And we'll mention harmonicas for health and happiness as well. So this is a collaboration with the BC Lung Foundation. It was a program developed by the COPD Foundation in the US, and it's hosted by Poplar Pulmonary Wellness. It's fully funded, so it's a free program where we learn to play the harmonica to learn some breathing techniques. So that is once a week. It's a 5-week program, so 1 hour a week for 5 weeks. And you can go check out our website if you want to learn more, or message us in the chat and we'll reach out for you. We do have room for people. We have 4 different sessions. Next one is, well, one starting this Friday and then another one in November. And if you do have specific questions about your health, the Poplar Clinic is open. You can book with a respiratory therapist, certified respiratory educator, and we can find a respiratory care plan for you specifically. And if you're looking for any more support and resources, you can check us out at poplarpulmonary.com or at bclung.ca. And thank you so much for joining. And what we like to say is get out there and live your best lung life.
Your best lung life.